Okay, so good evening, everyone. So we'll start with this monthly meet for the month of February. I request Padmaja Madam to take over for the welcome address.
Good evening, everybody. It's such a pleasure seeing everybody, at least virtually, after quite some time. This is actually the first scientific session of this year, and we are doing something ever so slightly different, yet ever so important for us to know which investigation is the one we order, and having got the investigation, to see for ourselves what it says and what the report says is what we actually see. So we are starting slightly differently with Dr. Veena Noronha, who's a radiologist and who shares something, a small, what shall I say, relationship with me. I'm sure I'm much older than her, but more than 50 years ago, I joined Lokmanya Tilak Sion Medical College as an undergraduate. And I see that she did her PG at my old alma mater. Of course, I did my ophthalmology after coming down south and getting married, which probably is the same reason that Dr. Veena moved south. Both our parents having worked probably in Bombay. Anyway, that's the reason why I grew up in Bombay. So, Madam, thank you so much for taking time out and helping us understand all the radiological investigations. We are so quick to order, but not as quick to interpret. And of course, I want to welcome all of you, Bhatsa, one of our very senior ophthalmologists. Such a pleasure seeing you. Welcome to the monthly meet. So also Dr. Ranjan, Dr. Ranjini, Dr. Laila, and Suma. Really a pleasure having all of you around. And with these few words, welcome to this monthly meet. Over to Dr. Veena, who will be introduced by Anju.
So before we start, we'll have the session moderated by Anju, who's working as an oculoplastic surgeon at Comtrust Eye Hospital. She'll be introducing our speaker. It will be followed by the talk, and then we'll have a PG discussion too. Now over to Anju.
Thank you, Bindu Madam. Good evening to all. Just share. Yeah. So as already Padmaja ma'am has very rightly said, for ophthalmologists, radiology is a very gray area. I should say it looks as gray as the CT and MRI images that we get. So that's the very reason that we have chosen this topic for the day. And what's better than to have an expert talk about the same. I am really privileged and honored to be introducing Dr. Veena Noronha to all of you. The very little radiology that I know, I attribute to her teaching. She, like you all know, she's a consultant radiologist at Sankara Netralaya as well as VRR Scans Chennai. She's a true Mumbai girl. She's done her PG, like ma'am said, at Topiwala National Medical College, Mumbai, and went on to do her PG at Lokmanya Tilak, Mumbai. She's highly specialized in orbit and neuroimaging. She's given numerous talks at state and national level, both in ophthalmology as well as radiology conferences alike. She has co-authored the book Atlas of Imaging in Ophthalmology, and she has numerous publications to her credit. In fact, she's so accurate in her interpretations that we have given her the nickname radiopathologist, because her diagnosis and differentials always correlate with histopathological diagnosis. So it will be great listening to her talk today. I hope
that Salman Aditi that may not be need to be watched. Is it that navy blue one?
So today, after her talk, we'll be having a short session where we'll have our PGs interpret a couple of images, which she'll be helping them and guiding them in doing the so that it will help them in their OSCE. So once again, a very, very warm welcome to Veena ma'am, and over to you. Veena ma'am, you're muted. We cannot hear you.
Thank you, Anju, for the kind introduction. I thank the organizers, especially Anju, who has been very persistent and saying that, ma'am, we need the talk. The dates were not okay, but I said, okay, we'll push it to March. She said, no, it has to be finished in February. So I said, okay, and here we are today. So I shall start sharing my screen. Okay, so I will take you through the role of imaging in ophthalmology. I think the screen is visible, right?
Yes, it is.
Okay. So what do we have? What are the imaging modalities that will help us to diagnose and manage the ophthal patients? We have CT and CT angiography, magnetic resonance imaging, which is utilized to image the brain, the orbit. To see the intracranial circulation, we have venography and angiography, digital subtraction angiogram, and positron emission tomography, also called as a PET-CT. So let's see what are the advantages and indications for each modality in ophthal. So coming to CT is definitely a cost-effective imaging, but not necessarily the modality of choice. It uses ionizing radiation to acquire images and therefore should be used with caution in children and women of childbearing age group. The advantages of CT are the bone details. So therefore it is used in trauma. It's highly sensitive to calcification. It is not the modality of choice in optic nerve pathologies, cranial nerve palsies, and posterior fossa. So in short, it is not the modality of choice in neurophthal. So what are the indications then when it comes to the eye? CT is generally used for trauma to look for intraocular foreign bodies. It used to be used in RB a lot to look for intraocular calcification. In the orbit, we generally use it for congenital bony abnormalities, in trauma to look for fractures, hemorrhage, and foreign body, thyroid eye disease, and for paranasal sinuses. So CT is still the modality of choice to image the paranasal sinuses. It is complementary to MRI when you want to look for bone changes and orbital tumors and look for erosion when you're suspecting an infection. So coming to neurophthal, it's got a very limited role, a disc drusen. We don't do an MRI. Of course, ultrasound is done for disc drusen, but in case you want to image further, you do a CT and not an MRI. For traumatic optic neuropathy, when you want to look for optic canal fractures, CT is the modality of choice. For intracranial hemorrhages and to look for aneurysm, we do a CT angiography. So coming to a contrast enhanced CT, what are the indications for a CECT? When you're suspecting tumors, infection, and vascular lesions, you order a contrast enhanced CT. The CT contrast is an iodinated contrast. Renal function is mandatory prior to contrast imaging, whether it is CT or MRI. The absolute contraindication for a contrast CT is prior contrast allergy and patients with acute renal failure. You avoid iodinated contrast in patients who have an acute thyroid storm. And if you're going to do a iodine uptake study or an iodine therapy for thyroid patients, then it interferes with the uptake and the dosage, and therefore you would defer the uptake study or the therapy. So coming to MRI, as everyone knows, it's excellent for soft tissue and therefore the modality of choice to image the brain and the visual pathway. It has no radiation and hence safer in children and women of childbearing age group. The limitations are cost, but I think now many patients can afford an MRI. Time and noise being the major drawbacks, and especially it is difficult or a challenge, I would say, to image children and critically ill patients. It's not so sensitive to bone changes and to pick up calcium. It's contraindicated in patients. It's a relative contraindication. It used to be an absolute contraindication, but nowadays the patients with pacemaker can undergo an MRI. What we do is we disconnect the pacemaker before the MRI if the patient is not entirely dependent on the pacemaker, and then we reconnect it after the MRI. A cochlear implant is still a contraindication. Patients with ferromagnetic foreign body is a contraindication to do an MRI. So then what are the indications in the eye? It is when you're suspecting tumors, inflammations and infections, you would do an MRI. Same with orbit, tumors, inflammation and infection. MRI is the modality of choice. In neuro-ophthalmology, the afferent and the efferent pathway, completely you would depend on MRI for diagnosis. We can do a CT MR angiogram with or without contrast for aneurysms, AVMs, and CCF. Earlier, we used to do a MR angiogram without contrast, but now we have something called as a dynamic contrast enhanced MRI, which will give you the AVM and CCF, the circulation. So it's basically a dynamic contrast. When you're injecting the contrast, the images are required. So you get the arterial and the venous circulation now in one acquisition. Same with venogram. We do a venogram which can be with or without contrast in patients with idiopathic intracranial hypertension and dural venous sinus thrombosis. So coming to DSA, digital subtraction angiogram is still the gold standard for imaging intracranial vascular malformation, especially AVM and AV fistulas. It's not a diagnostic modality for aneurysms any longer because we do a CT angiogram or an MR angiogram. For treatment of aneurysms, AVM, definitely we would do a DSA to map out the vascular malformation. So let's start with the orbit. Since Anju invited me, I thought I'll start with her specialty first. So I will just deal with the three structures of the orbit: the optic nerve, the extraocular muscles, and the lacrimal gland. So coming to optic nerve pathologies, you should remember that MR is the modality of choice. If you have a patient with an optic nerve dysfunction, other than trauma, you would order an MRI, and especially a contrast enhanced MRI. Patients with traumatic optic neuropathy, you would do a CT for an optic canal fracture. If you're clinically suspecting an optic nerve avulsion, you will do an MRI. For tumors of the optic nerve, CT is complementary, especially in optic nerve sheath meningiomas, to look for calcification. So I'll go through a few cases. Here is a 24-year-old female with a painful loss of vision. On clinical examination, she had bilateral temporal pallor, left more than right. Now, if you have to see an image for optic nerve of a patient with an optic nerve dysfunction, a T2 weighted image is the sequence that you should look for, and especially with fat suppression. So how do you, for the PGs, how do you identify a T2 weighted image? Is you look at the CSF. Okay, so these are all the sulcal spaces with CSF, and they are bright. So that's a T2 weighted image. And you can see these rounded structures here. This is the optic nerve in the center. And the white circumferential white signal that you see is that of the CSF. So this is the right optic nerve and the left optic nerve. If you look at the right optic nerve, the signal in the right optic nerve should match that of the white matter because it is basically a white matter tract. So if you compare the two optic nerves, you can see that there is a bright signal in the left optic nerve. The same, we do something called as a diffusion weighted imaging, where you can see that the left optic nerve is very bright along the entire length of the orbit. And then you do a contrast enhance to look at the enhancement pattern in the optic nerve. And if you compare to the right, you can see the left one is brighter. So this is the enhancement in the left optic nerve. Now, a patient with optic neuritis, the study is incomplete if you do not include the brain. So this patient had a brain imaging, and you can see here the multiple periventricular lesions that are there. The typical Dawson's fingers, which are perpendicular to the body of the lateral ventricle. We give contrast in these patients to look at the active plaques in the brain and the pattern of enhancement. And then you do a spine screening to look at the cord lesions, okay, the intramedullary plaque. So this is the complete imaging protocol that we use for any patient of optic neuritis. Spine imaging is not always done, depends on the clinical setting because that adds to the cost to the patient. So we don't generally include spine imaging in our protocol unless the neurologist requests for the same. So this is a patient who came very recently. It's a 30-year-old female who came with headache and a painful blurring of vision of 4 days. She received IVMP And based on the clinical and imaging findings, they gave her IVMP. So this was her imaging, which was done on the 7th of February. And you can see that there is the enlargement of the left optic nerve compared to the right side. You can see the normal optic nerve on the right. This is a contrast enhanced coronal image, T1 weighted. You can see the sphenoid sinuses, and you can see the enhancement in the left optic nerve. This is the actual image of the same, showing you the enhancement in the optic nerve. She received IVMP, but not with much clinical improvement, and therefore she was referred for a repeat imaging just 2 days back. And what you see here is almost doubling of the optic nerve. Okay, so the intracanalular and the intracranial optic nerve has almost doubled. You can appreciate it very well on the coronal, and look at the contrast enhancement. So this is not a behavior of a typical optic neuritis. There is also some dural enhancement over here. So this is an atypical optic neuritis. You can see the involvement of the chiasm, and she also had involvement of the optic tract. Now, coming to optic nerve tumors, the commonly seen tumors are optic nerve gliomas and optic nerve sheath meningiomas. Of course, they occur in two different age groups. Meningiomas are seen in younger patients of NF. So this is a child who had a proptosis of the right eye. Now, if you see, this is an actual contrast image. This is a SAG T2 image. You can see the CSF is bright, your vitreous is bright. So this becomes a T2 sequence. So basically, one is you see whether the mass which is there, it is predominantly intracorneal. You look at the optic nerve, if you can identify the optic nerve separately or not. If it is not, then is it arising from the optic nerve? And then you look at the posterior extent. So this is the canal. The same is appreciated on the actual CT, where you can see the widening of the right optic canal and the normal left optic canal. So this is an optic nerve glioma. You cannot mistake this for any other tumor. Okay, so this is just to show you how the optic nerve glioma would look versus a meningioma. So what you see is a very fusiform intracorneal mass. You can see the enlarged optic nerve in the center. This is involvement or the infiltration of the perioptic space. But here the posterior extent is just up to the canal. The intracranial optic nerve is not involved. So this is where MRI plays a role to help you to see the posterior extent of the tumor for your tumor planning or management. So this was another very unusual case, a 43-year-old male who was sent to us with a OS query, early disc edema, query compressive, query inflammatory. The history was very short. It was just 1.5 month duration, had a double vision and proptosis with EOM limitation. So what we see here is a thickened optic nerve towards the posterior orbit up to the canal. This is a T2 showing you how dark the signal is vis-a-vis optic neuritis, which is very bright. And you can see the contrast enhanced image here, which is showing you the optic nerve here and a perioptic lesion. But something was okay because the history was too short. Though it looks like a meningioma, the history was not very correlated because of the short duration and the EOM limitation. So we thought, let's get a CT scan done and do a CT and see what it is like. And here you can see the calcification. So this confirmed that it was an optic nerve sheath meningioma. So this is where CT would complement in these patients when you have a doubt for a meningioma. Of course, calcification is not always present, but when it is present, it will help you in arriving at a diagnosis. Coming to traumatic optic neuropathy, CT is the modality of choice. You have to image the optic canals in two planes, the axial and the coronal plane. Just like when you take an X-ray, you take an AP and lateral view. Same in the orbit, you have to do an axial and coronal imaging. A SAG is an additional plane depending on where the fracture or where the lesion is. Remember, it has to be thin slices. There should be at least 1 to 2 millimeter thick slices. So here is the actual image showing you the normal left optic canal. And you can see the fracture of the medial and the lateral wall of the optic canal. But the best image to see the fractures, the compression and the fragment within the canal is a coronal image. So you can see the roof of the optic canal fractured. The optic strut is fractured. The normal optic canal should appear like a complete ring over here, and you can see the fractures, and there is some narrowing of the canal. So this is a 20-year-old male who presented with no light perception following trauma with a clinical suspicion of a optic nerve avulsion. We did an MRI, but because of the eye movement, we were not able to establish any connect of the optic nerve with the globe. So we didn't know whether there was avulsion or this blurring was because of the ocular movements. So we did a surface coil imaging. I'll come to it later. What is a surface coil imaging? And you can see the clear-cut avulsion of the optic nerve from the lamina. So the SAG imaging is even more clearer. So this additional imaging plane can be determined based on the clinical setting. So when you are suspecting an avulsion, you do an MRI. When you want to look at the fractures, you do the CT. So coming to extraocular muscles, enlargement of the extraocular muscles occurs in thyroid eye disease, myositis, cysticercosis, CCF, lymphoma, and metastasis. A unilateral or bilateral proptosis is seen in thyroid eye disease, lymphoma, METS, and CCF. So here is a patient who can be easily clinically diagnosed based on his clinical eye signs. So why would you do an imaging? One is to look at disease activity, for which you would do an MRI, to confirm the diagnosis, to look at radiological disease activity, and look at the contralateral orbit if there is any clinically silent disease. So what are the imaging findings of thyroid eye disease? You look for the proptosis, you draw a line from the interzygomatic line, and then you see how much of the globe is above the line. You look at the orbital fat. Now in this particular patient, you can see the gross proptosis, but the muscles are not much involved. But what is more is the orbital fat. So you can see there is a lot of fat between the medial wall and the medial rectus. Generally, a lot of fat in the intraconal space. And there is also herniation of the fat through the superior orbital fissure. So this is just proptosis because of the increase in the fat volume. The next finding is the involvement of the extraocular muscles. So it goes in the order of inferior, medial, superior, and the lateral. Isolated LR involvement is very unusual for a thyroid eye disease. So you do an MRI basically to look for the disease activity. So how would you identify the disease process on MRI? You look at a coronal T2 weighted image. Now you can see the CSF is bright over here. So this is a T2 weighted image. Now look at the right muscles. They are all normal. They do not show any altered signal. This is the normal T2 signal of the muscle. Whereas you look on the other side, that is the left side, you have the inferior, the medial, the superior, and the lateral muscles involved. But the muscles are showing different signal, like the inferior and the medial are brighter, and the superior and the lateral are darker, which means that the inferior and the medial have active disease, which means whenever anything is bright, any pathology is bright, the water content is more and it is edema. When anything is dark on T2 weighted image, that means there are compact cells, there is fibrosis. Sorry. So here is a left orbit showing you muscles in different stages. So you have active disease in the inferior and the medial, and you have a chronic disease in the lateral and the superior muscle. So this was a patient who came just 2 days back, a 30-year-old female with history of diplopia. So they said to look at the extraocular muscles also. So here is a coronal T1, which shows that there is nothing remarkable in the extraocular muscles. They're looking fairly okay on a T1 weighted image. We did look at the T2. You can see that there is a bright signal in the right inferior rectus against the normal appearing left inferior rectus. If you can see, it's mildly, very subtle enlargement of the inferior rectus. So you need to do a fat suppression T2, and you can see the bright signal in the inferior rectus. So this was isolated inferior rectus involvement, and you can see the active disease in the inferior rectus. So this was also a thyroid eye disease. Coming to myositis is unilateral. Any muscle can get involved. The tendon and the muscle bundle is involved. So here is a patient who has an isolated LR involvement, which is not a feature of thyroid. If you look at the tendon is spared, but the muscle signal is very heterogeneous. So we know that this is not a thyroid eye disease. We thought it was something infiltrative, and the histopath turned out to be a chronic inflammatory etiology. So cysticercosis is something which is a radiological diagnosis, and it's a spot diagnosis. You cannot miss a cysticercosis. So if you have an isolated muscle involvement with a cyst, you can see the cyst very well on a T2 weighted image. It's got a uniform wall, the fluid is bright, and then you can see the scolex over here. So one should not miss a cysticercosis. So this is a 45-year-old female with bilateral proptosis of long-standing duration. You can see that there is some kind of a redness over here. And this is the imaging which is showing you very bulky soft tissue in the bilateral lateral orbit. Now it's not general, it's on this side you cannot see the lateral rectus, but on the right you can see the lateral rectus being displayed. So this was not thyroid, this was not inflammatory because it was chronic progressive proptosis. So this was a patient of lymphoma. You can see the diffusion sequence where it is very bright. So diffusion sequence is one sequence which can diagnose lymphoma in 95% of the patients. So this was a 30-year-old female with a history of CA breast, and you can see the lateral rectus being involved. So in patients with metastasis, usually the muscle that is involved appears very nodular, very bulky, and very irregular. So if you have a pattern like that, then we should think when a patient with a known CA, we should think of a metastatic involvement. So coming to lacrimal gland pathologies, MRI is superior to CT to characterize the lesion. The commonly seen pathologies are inflammatory and tumors. In the tumors, we see generally pleomorphic adenomas and adenoid cystic carcinomas. Now, in inflammation of the lacrimal gland, what is the imaging finding is you generally see a diffuse enlargement of the gland involving both the orbital and the palpebral lobe against a tumor where only the orbital lobe is involved. You must remember the shape of the gland is maintained. It generally does not have rounded contours. There is a lot of periglandular inflammation, and the signal will depend on the stage of inflammation. If it's an acute inflammation, it will be bright. If it's a chronic inflammation with fibrosis or granulomatous, it will be dark. So here is a CT showing you a diffuse enlargement of the left lacrimal gland. You can see the normal right lacrimal gland here. So you can see the oblong shape of the gland is maintained. You can see the fat here. There is a lot of fat stranding and periglandular inflammation. So in an appropriate clinical setting with this kind of imaging findings will help you to arrive at the diagnosis. So coming to tumors, remember the pleomorphic adenoma is the most common tumor that we see. They usually have a very rounded contour. They are long, by the time they present, they would be there for a couple of years, and therefore they cause a bony remodeling, what we call it as a fossa formation. So here is a CT of a pleomorphic adenoma. You can compare it with the dacryoadenitis. You have a rounded contour over here. You can see the remodeling of the bone. Okay. MRI would help to basically characterize these tumors to see whether there is a solid component, whether they're mixed solid or cystic, or whether they're predominantly cystic. So the same patient, you can see here the composition of the tumor. It's a fairly solid tumor. It shows you the tumor capsule. So if there is any extracapsular involvement, MRI is far superior to CT. Adenoid cystic carcinomas are seen in younger patients. They usually have a shorter history. They have a history of pain, and on imaging, they generally have very irregular margins and may have bony erosion. So here is a patient showing you a large mass in the superotemporal quadrant. It has caused bone changes. There is some kind of a calcification, and there is intracranial extension. So with this kind of a pattern, you know that you're dealing with some kind of a malignant tumor of the lacrimal gland. Coming to trauma, CT is the modality of choice to image fractures. X-ray is done only in an emergency situation where CT is not available. So it's kind of become an obsolete now. This was a Waters view showing you the typical teardrop sign in the floor fracture. And you can see the corresponding coronal CT image of the teardrop sign here, the fracture of the floor. And this is another patient to show you the entrapment of the inferior rectus muscle and the herniation of the orbital fat. So you need to have it imaged in two planes because you cannot see the extent of the fracture or the entrapment on the axial plane. The coronal plane is the best plane to look at the floor fractures. Medial wall fractures, an axial image is best because you can define the entire length of the medial rectus and the anteroposterior extent of the fracture. So here is the patient showing you a medial wall fracture. Now you can see the axial view is actually telling you how much is the anteroposterior extent of the fracture. The coronal view is showing you the entrapment of the medial rectus into the ethmoid sinus. And then you can see a lot of retrobulbar hemorrhage. Coming to superior rim and roof fractures, you have to be very careful when you're dealing with patients with roof fractures because quite often they might present with CSF leak and therefore you have to see them in the coronal plane. So this is a patient with a fracture of the walls of the frontal sinus. So we have to look for this inner table or the roof of the frontal sinus because the fracture of this is the one which is troublesome and can produce CSF rhinorrhea. So coming to evaluation of foreign bodies, intraocular or orbital foreign bodies, the form and the composition of the foreign body is extremely important to determine the modality, the imaging modality. So for intraocular or foreign bodies, you can do an ultrasound or a CT. CT has to be thin sections, at least 1 millimeter slice thickness. It confirms the presence or absence of foreign body. It localizes the foreign body, whether in the globe or the orbit. And based on the Hounsfield unit, it can tell you what is the composition of the foreign body. So here is a typical metallic foreign body. You can see these streak artifacts which are seen in the metallic foreign body. And they are generally, the Hounsfield unit of this foreign body is generally more than 2000 Hounsfield unit. So how the Hounsfield unit is calculated is we just put a cursor or a ROI on this particular foreign body and the computer automatically calculates it for you. So if the Hounsfield unit, this does not require any Hounsfield unit, the streak artifacts itself can tell you that it is a metallic foreign body. So now this is a patient with a road traffic accident and you can see multiple foreign bodies. Though they are big, none of them are producing any metal artifact. So these are nothing but glass foreign bodies. The glass foreign body Hounsfield unit will vary between 400 to 600, depending on the type of glass, whether it is windshield glass, whether it is tube light, whether it is mirror glass, etc. Now, while imaging a wooden foreign body, one has to be very careful. You can do a CT or an MRI, but you should know what is the imaging appearance of a wooden foreign body on CT and MRI because they can be easily missed. Now, as you can see the foreign body here, it is such a tiny fragment, small dense fragment over here, and all this is the surrounding reaction to this wooden foreign body. The CT density of the wooden foreign body varies anywhere between dark to bright, but on MRI it is always dark. So you can see this dark line over here within this enhancing soft tissue is the foreign body. So imaging patients with retained wooden foreign body, one has to be very, very careful. So coming to imaging the eye or the globe, MR is the investigation of choice for tumors, inflammation, and infection. For trauma and foreign body, again, you do a CT. When you're imaging the globe, what we do we do a different technique, what is called as a surface coil imaging. So what is a surface coil imaging is this is a routine head coil which is used for brain imaging. When we need to study the globe, we put a ring on the globe so that the signal to noise ratio, because the globe is in contact with the coil, the signal to noise ratio is much better and smaller lesions are easily picked up on this type of technique. So I'll just deal with RB, which is a common pediatric tumor for which the patients are referred from the retina department. So we basically do the imaging to confirm the diagnosis, to look for choroidal invasion when we give contrast. extraocular extension, optic nerve invasion, and brain metastasis. So it has to be an MRI brain orbit with contrast. We no longer do CT. Initially, CT used to be the modality of choice for calcification, but now MRI can pick up the tumor itself. So we don't need to look at the calcification to diagnose an RB. And in addition, MRI will tell you the optic nerve invasion, extraocular extension, and brain involvement. So here is, this was a CT years back when we used to do CT for RB. So you can see they are all different patients. You can see the type of calcification that you see in RB, a clump-like calcification. You can see multifocal speck of calcification. Here is a single calcification, and some are not very dense. You can look at the optic nerve here, which is thickened. Okay, so this is the different pattern of an calcifications that you would see in an RB, and how CT would use to help us in identifying these tumors. So coming to MRI. Okay, so MRI here is, you can see the retinal detachment over here, and the mass, that is the retinoblastoma, is T2 hypointense. So you can clearly see the mass itself on MRI, whereas on CT you can see the calcification. So you cannot identify the tumor extent per se on a CT, but based on the calcification, you will say that, okay, this is a retinoblastoma and the tumor is in the temporal quadrant. Whereas on MRI, you can really see the size of the tumor. So coming to choroidal melanomas, this is what we have used as a surface coil technique. Now you can see the definition of the tumor is very good because we have used the surface coil. Melanomas are T1 bright, so very easy to diagnose. They're dark on a T2. The shape is very typical, the mushroom shape. The extraocular extension, we have to look for this low signal sclera. So any discontinuity in this particular line will tell you that the melanoma has breached the sclera. So this was a very interesting case who came recently, a 30-year-old female who complained of some blurring of vision. She was from Nepal. She was investigated elsewhere, had a biopsy also done, which was inconclusive. So this is a surface coil imaging showing you a ciliary body mass, which is very ill-defined. You can see the T2, the margins are a little better. And on contrast, it is showing some kind of a enhancement. Now, the study is incomplete if you don't do a brain imaging. So she had a brain lesion. And because of that, she had a systemic evaluation. She had a PET CT, which showed a pulmonary nodule, which was a single nodule, and she had multiple mediastinal nodes. So the diagnosis was, are we dealing with an atypical melanoma or are we dealing with metastasis? Because the imaging features were not of a granuloma or a tuberculoma. So she underwent a ciliary body biopsy just 2 days back, and this turned out to be a metastatic carcinoma. So coming to brain imaging, we'll start with the chiasm. MR is again the preferred modality to look for in patients with bitemporal field defects or chiasmal lesions. Since these tumors are very large at the time of presentation, you can, contrast may not be mandatory, but it's better you do the contrast study to know the exact extent of the tumor. And in chiasmal lesions or pituitary or suprasellar lesions, we need to image them in all three planes, that is the axial, coronal, and sag. So the typical pituitary adenoma showing you expansion of the bony sella. You can see the suprasellar extension. You can see the chiasmal displacement over here. So this is where MRI is much better than CT because you can see the blood vessels without giving contrast. You can see encasement of the vessel. You can see the chiasmal displacement. It will tell you whether the tumor is solid or cystic. So this basically guides the neurosurgeon in removing the tumor or planning the surgery. So suprasellar meningioma, you can see that the sella is not expanded. The pituitary is seen separately and the tumor is completely suprasellar, and which is causing chiasmal compression. Imaging retrochiasmal visual pathway of patients with field defects. If they are acute field defects, one would do an MRI to look for acute infarcts. If it is chronic, you can do an MRI or CT because by the time there would be a gliosis, etc. You do a contrast if if you're suspecting an infection, demyelination, or a tumor. So this is a typical patient with a right homonymous hemianopia acute, showing you a left occipital lobe infarct. So this was a very interesting patient who came few months back. He was a 40 years old male who came with sudden onset decrease in temporal vision of 15 days duration with a clinical diagnosis of a right homonymous hemianopia. We did a FLAIR imaging and did not show anything really significant in the occipital lobe. The diffusion weighted imaging also did not give us anything. Now it's a young patient with a right homonymous hemianopia, and to have a near normal brain scan is very unusual. So we do a complete brain imaging and then we pick up something over here, which is a gradient imaging, and you can see some kind of a black spot here. We went ahead with the contrast MRI and you can see a vascular malformation in the occipital lobe. This is very unusual, but one should remember that if you're seeing a patient with a homonymous field defect and the scan is normal, it's better to always get a contrast enhanced MRI done. So this is the whole thing of getting an MRI done and studying each and every sequence. Whereas CT, you have just one image, whereas in MRI, you need to look at each and every sequence to arrive at a diagnosis. So this was just a left occipital arteriovenous malformation. Coming to cranial nerve palsies, whether they are isolated, multiple, localization is important to the radiologist as well as to the clinician, because it will guide us as to where we need to focus and look at the cranial nerve. As a protocol, contrast is done for almost all patients, except if it's an elderly patient and he's a diabetic and the scan is normal, then we don't go ahead and give contrast. Angiogram is done for third and sixth cranial nerve palsies. A diffusion weighted sequence is a very important sequence in these patients. I'll show you, this is a 72-year-old male who came recently with the pupil sparing left third nerve palsy. And you can see the MRI at the level of the midbrain. You can see a bright lesion over here. This is a T2 sequence, again showing you a bright lesion, and look at the DWI. So an elderly patient having a bright signal on a diffusion weighted image means that it is a recent infarct in the midbrain causing his pupil sparing third nerve palsy. So it's exactly in the region of the fascicle. So this is the interpeduncular fossa. This is where the third nerve would exit from the midbrain, and the infarct is just lying over there. So this is where localization is very important, and it will guide the radiologist as to where exactly one should look for. So a pupil involving third nerve, one has to be extremely careful. Now, this is a 47-year-old female who presented with a left pupil involving third nerve palsy of 3 months duration. She had a CT angiogram which was done outside, which was reported normal. So we repeated the imaging, we did an MRI, and what we saw here was a nice aneurysm which is compressing the third nerve. This is the MR angiogram which confirms the aneurysm at the origin of the PCOM artery. So this is all pupil involving third nerve palsies need not be aneurysmal. So this was a doctor who came with a pupil involving third nerve, and then we were looking for aneurysm, and then the contrast enhanced scan showed us some granulomatous lesion here in the left superior orbital fissure and cavernous sinus. You can tell me if I need to stop at any time. So imaging fourth nerve palsies with post-traumatic fourth nerve palsies also, you need to be very careful to look for all these bleeds in the region of the course of the fourth nerve. So coming to sixth nerve, now sixth nerve is one cranial nerve which you need to be very careful because it's got a long subarachnoid course, and therefore your imaging should start from the skull base to go up to the cavernous sinus. So here is a 28-year-old female with a painful left sixth nerve palsy. And what you can see here is a very small enhancing lesion in the Dorello's canal. So the sixth nerve here, what is seen here is the sixth nerve, which is encased by this inflammatory soft tissue. So unless you do thin section and you do a contrast scan, these lesions can be easily missed. So this is typical TB meningitis with multiple granulomas. So basically the sixth nerve is because of the basal meningitis. This is a typical cavernous sinus lesion showing you a homogeneous enhancement, a cavernous sinus meningioma. So basically to show you that how a contrast enhanced MRI would help in identifying and coming to a diagnosis in these various pathologies. So when you have a patient with an internuclear ophthalmoplegia, it's a very small area. It traverses along the brainstem, and therefore one needs to do thin section imaging of the entire brainstem. And you can see here the bright lesion on the DWI image. So this was an acute demyelination in the region of the MLF. So coming to multiple cranial nerve palsies, again, localization is very important. A contrast enhanced MRI is mandatory in patients with multiple cranial nerve palsies. You look at the paranasal sinuses, you look at the cavernous sinuses, and if there is a sinus disease, you do the CT to see if there is any bone erosion. So this is a typical SOF syndrome. You can see a soft tissue. Now, an SOF is a very small area. Unless you do thin sections, a routine brain imaging can easily miss a SOF lesion. And therefore, you have to mention to the radiologist that you're looking to concentrate on the superior orbital fissure or orbital apex or cavernous sinus. So this is a very small soft tissue here in the SOF region. You can see the normal right SOF and the actual imaging of the same. So you have to mention it to the radiologist. So this is a 32-year-old male with a sudden onset right proptosis and ophthalmoplegia. So the imaging coronal T2 shows you that there is some kind of a process which is going on in the right orbit involving the extraocular muscles, the retrobulbar fat, the optic nerve. So with this kind of a pattern with multiple cranial nerve palsies, we know that there is something going on in the cavernous sinus. So here is the optic nerve imaging showing you ischemia of the optic nerve, and the contrast enhanced MRI showing you no enhancement in the cavernous sinus. So a patient of suspected cavernous sinus thrombosis, you have to do a contrast enhanced MRI focusing on the cavernous sinus. Another thing to look for is a patient with a chronic ophthalmoplegia. You look at the cavernous sinus, but at the same time, you need to look at the skull base. So here is a patient who has a left cavernous sinus lesion, which is completely encasing the internal carotid artery. It was of 6 months duration, so definitely there is something going on. And you can look at the contrast where you can see the lesion is actually in the nasopharynx, has got a perineural extension into the cavernous sinus. So that's why in a patient with sixth nerve palsy, you need to look at the skull base, especially in chronic ophthalmoplegias. So to summarize, if you want to look at fractures and foreign bodies, you do a CT. For tumors, inflammation, infections, you do MRI. For optic nerve, except for trauma and drusen, you do MRI. And you avoid unnecessary CT in children and young women. Thank you.
Thank you, Veena ma'am, for that fascinating yet lucid talk. We just didn't want to tell you to stop. So that's why we let you go on. Thank you so much.
Thanks, Anju.
I think we can have the OSCE session. I'll just share my screen.
Anju, you're going to introduce the PGs, no?
Yeah. So for the first OSCE, I call upon Dr. Mona, who's doing her PG at Malabar Medical College. Mona, are you there?
Yes, ma'am.
Yeah. Can you go ahead and interpret the two scans that you see here?
Okay. So the first image shows the CT image in coronal section showing left orbital floor fracture with hemosinus. And the second is the CT image, but sagittal view with the displaced bone fragment.
And regarding the muscle?
The muscles are intact except from slight, I think it's a orbital fat protrusion.
Okay. Veena ma'am, would you like to add some points or guide her?
Yeah, so basically when you're looking at fractures, you need to look at them in two, one is two planes and two window settings, okay? There's something called as a bone window and then there is a soft tissue window. So when you want to look at the bone, now what you have shown are two bone window settings, coronal and sagittal. So if you want to look at the muscle, whether it is entrapped or just edematous or avulsed, you have to look at the soft tissue window. Okay, so oblique sag is a very useful imaging plane when you're looking at floor fractures, because you can, with the present day helical scanners, you can actually just do an axial acquisition and you can do the reconstruction in any plane you want without, changing the position of the patient. So you need to do an oblique sag, which is parallel to the optic nerve or the inferior rectus. So you can actually see the entire length of the inferior rectus from its scleral insertion to the apex. Now, since you have shown the bone window over here, it's very difficult to comment on the inferior rectus. But whatever I can see, the inferior rectus seems to be intact. It is normal in position. Yeah, that's correct. There is just some amount of edema of the fat between the inferior rectus and the fractured floor. So basically, this will help the orbit surgeon to know the anteroposterior extent of the fracture, so that they can then decide on what kind of a repair they're going to do and what is the plate they're going to place, right, Anju?
Yes. And are they expected to comment, or can they comment about the extent of fracture with the SAG section?
Yes, of course. You can see the entire length of the fracture, no? So, but only on this section, then you cannot say whether the rim is involved or not. Okay, so for the rim to be involved or not, you need to see the anterior most section, or you see the 3D CT image that is given to see whether the rim is involved or not.
Okay, thank you. Thank you, Mona.
Thank you.
Next, I call upon Dr. Jinju, who's doing her residency at KMCT Medical College. Jinju, are you there?
Yes, ma'am.
Yeah. Please interpret these images.
Ma'am, this is the T1 weighted. First one is the T1 weighted MRI image. First one showing the coronal view and the second one showing the axial view, wherein we can see that there is hypertrophy of the extraocular muscles, especially there is hypertrophy of the medial rectus of the left side.
Okay.
Then also there is tendon sparing. And the second image is T2 weighted image showing the coronal and the axial sections. There is also muscular hypertrophy.
Okay. And would you like to give your DDs?
Differential diagnosis. First one is, since it is bilateral, we'll go on with thyroiditis. And there is tendon sparing. But if the tendon was involved, we can consider a differential diagnosis of myositis.
Okay. Yeah. Veena ma'am, would you like to?
Why would you think of myositis in this kind of muscle involvement? Bilateral, almost all the muscle groups are involved.
No, ma'am, not in this case. Myositis will be often a single muscle will be involved, and it will
so
be.
Basically, I think she has differential diagnosis in this particular patient, right?
Okay.
Okay, so you can see that the tendon is spared. You have almost ballooning of the muscle belly. If you look at the coronal, all the muscles are involved, and all the muscles are showing almost similar T2 signal. That is, they are all bright on T2. Okay, then you look at the apex for the crowding. There's something called as a Barrett's index. You know what is it?
Yes, ma'am. Barrett's index can be used to know if there is any compression of the optic nerve at the apex. If the index is more than 67%, we will take it as a case of apical crowding.
Okay, and how do you calculate it?
We can take the ratio of either the vertical muscle and the horizontal muscle, and then we'll take the total dimension.
Yeah, so you take the height and then the thickness of the two muscles. Okay, and then the horizontal also the same thing. You take the width and the thing. So you add up the two muscles and then divide it by the width, right?
Yes, ma'am.
Okay. So that's fine.
Yeah. So thank you so much, ma'am. Any tips or pointers for PGs?
Any questions? Anybody has any doubt?
I guess everybody has a lot of doubts to clear
Yes.
because it was a very interesting talk.
Wonderful coverage, Dr. Veena, Madam. Very, very interesting. You have covered each section by section very clearly. I just wanted to know, actually recently we had a patient, I don't know, something happened to my screen. I can't see anything.
Yeah,
You can hear me.
Yeah.
You can
Yeah.
hear me.
Yeah.
Recently we had a patient who was being followed up for actually congenital ectopia of uvea, and she had presented with some amount of proptosis. So we had imaged her at 2.5 years, and later after another 2 years, 2.5 years, we came to know that she had some changes of neurofibromatosis in the showing some dysplasia of sphenoidal wing. So is it possible to have it as an acquired presentation, or did we miss it in the first place, just to know?
What was the imaging that was done? Did you image her at that time?
Yes, we had imaged her at 2.5 years because.
What did you do? A CT or an MRI?
MRI. No, first one was a CT. First one was a CT, then MRI.
Okay, it is difficult to miss a sphenoid wing dysplasia on CT. But if the dysplasia varies, the degree varies. Sometimes it's like complete absence. Sometimes it is just a mild dysplasia. So if it is a very mild one, it can be easily missed because, you don't look at the bone window often, especially when you have sent a patient for imaging the soft tissue. So that can be easily missed, a sphenoid wing dysplasia. If you do MRI, definitely you will miss it because it's not that easy to identify unless it's a big defect and, the temporal lobe herniates through the thing. The shape of the lateral wing, like if you have seen many cases and, when you look at the greater wing of the sphenoid, you'll have a you'll have a radiological suspicion that, okay, the sphenoid wing does not look normal. Then is when you go back and then check whether there is a dysplasia. But if it's a very small dysplasia, it can be easily missed.
Okay. Actually, we didn't suspect NF1 at that time. When she presented with proptosis, she had a large anisometropia with myopia. So we were thinking the proptosis is sort of a pseudo prominent eye because of the myopia. But then now she has a progressive proptosis and she has cafe ole. Everything is there, which fits into NF.
Okay.
Now, any other doubts?
One more thing I want to ask is when we look at the extraocular muscle imaging, especially if there is any atrophy, hypoplasia, which coronal image, what section or what is the area to focus?
See, depending on the muscle that you want to see. Suppose you want to see the horizontal muscles, you look at them in the axial plane because that is the plane, the muscle plane, If you want to look at the superior and the inferior rectus, a sag oblique is the ideal sequence because that will cover again the entire length. If you want to look at the obliques, the superior oblique, the axial plane is best because you can see the trochlea, you can see the tendon, and you can see the muscle in a single plane. Inferior oblique, again, you cannot see it in any other plane other than coronal. Okay, so it depends on what muscle you're looking for. And again, you look at both the T1 as well as T2 because T1 will give you the anatomy well. The T2 will tell you whether the muscle is normal or abnormal. Okay, whether it's a fibrosed muscle, whether there is some kind of edema, the T2 will tell you. If you want to just look at, the orientation of the muscle, the anatomy, then a T1 is a good sequence.
Okay. Thank you.
Any more doubts?
Madam, can I ask one question?
Yeah, definitely. Go ahead.
Veena, madam, we had actually one patient, a 50-year-old lady, who developed after head injury a bilateral caroticocavernous fistula, and she underwent embolization. And the neurosurgeon said they felt they had a successful embolization bilaterally, but on the very next day, patient symptoms, the proptosis, redness, chemosis, everything increased on one side, but it was completely subsided on the other side. So it was a bit of a rare scenario for the neurosurgeon also. And when we went through the literature, this kind of a complication could happen after an SOV obstruction post-procedure. So I was wondering, if we are in a situation like this, what would be the best imaging modality to pick up the finding?
So it depends on how did they treat the CCF? Okay.
It was an arterial embolization.
No, with what? What did they use? Did they use coil or did they use
coil?
Okay. So most of them are titanium coils and they are MR compatible. They don't give that many artifacts. Okay, but we've had a couple of patients. I don't know when Anju was there, whether these patients were treated. They actually, what happens is post embolization of these CCF, they can land up with either a thrombosis of the superior ophthalmic vein or the cavernous sinus. So that's when you have an acute exacerbation of the symptoms immediately following the embolization. So that's the first, that's the most common cause what we have seen in our patients following the procedure.
Okay. And what was done for them, madam? How did they manage it?
I think they were just, they were just observed, I think.
We have been observing this patient for around 2 weeks now. It did come down
observed,
a bit.
And I think you give them the symptomatic, whatever treatment, thrombosis of the SOV.
Okay. Thank you.
Yeah, we have a question by Dr. Soumya. In cranial nerve palsy, especially sixth nerve, do we have to write for skull base to be looked into specially, or is there any particular section to identify the muscle pulley?
No, actually, what happens is if the radiologist is good, they themselves will do the imaging, because as a protocol, you need to trace the nerve right from the nucleus to the end organ. So as you look at the nerve from the nucleus, which is at the pons, and then you look at the subarachnoid pores, and then you look at the cavernous sinus, you look at the orbital apex, you look at the LR muscle. If you follow it very systematically, there is the question of missing a lesion in the course of the sixth nerve is highly unlikely. So if the radiologist is kind of trained and, to see the sixth nerve, then you don't have to write skull base imaging. So basically, you need to tell the radiologist that you are looking for a sixth nerve to look at the sixth nerve. Because if you just write MRI of the brain and then send the patient, you don't expect the radiologist to know what's happening there.
Yeah, so that's a question. As a radiologist, what is it that you would expect an ophthalmologist to mention a bare minimum when you send for in a scan?
Like, see, if it is a cranial nerve palsy, I think you should mention what is the nerve palsy, if it is single or multiple. Okay, that is important. Then based on the age group and the other factors, then we decide on the contrast. If it's a young patient, non-diabetic, we 100% do a contrast imaging. So we have a set protocol for third nerve, fourth nerve, sixth nerve. So it's like, irrespective of whether I am there in the center or not, the protocol is followed. So that, in many centers, they do it that way. For optic nerve, I think to mention the visual, you need not, if you write suspected optic neuritis also is fine. Otherwise you write, the visual acuity, the color vision, RAPD, all that helps. But for that, the radiologist also has to be trained to the opthal setting. Okay, but if you write an optic neuritis, it's good enough because then automatically the optic nerve will be imaged.
Hello, good evening, Padmaja madam, Dr. Bindu, Veena madam. I have a doubt similar to Dr. Nirmal's case. Am I audible?
Yeah, Ranjini
Yes.
madam, you are.
Yeah, we had a few cases of suspected indirect CCF. Madam, is it mandatory to do DSA in all these cases or just MRI with contrast is enough?
No, DSA is still the gold standard for imaging patients with CCF, whatever direct or indirect, because one MRI is still not come to that level where it can type the CCF. Like a direct CCF will be able to say, but whether it is, type C, type D, it's difficult to comment on MRI with contrast or even a dynamic contrast enhanced MRI. So that's where the DSA helps. And then you can do the treatment planning based on the type of CCF. The interventional radiologist will then decide what is the best treatment for that particular patient. So still for a CCF, DSA is the modality of choice. Even for arteriovenous malformations, DSA is still the gold standard. Only for aneurysms, to diagnose an aneurysm, we no longer do a DSA. So for diagnosing an aneurysm, we don't do a diagnostic DSA anymore. It's either a CT angiogram or an MR angiogram.
Okay, thank you, madam. So we will ask for screening DSA or?
No, there's nothing called a screening DSA. It's a 4-vessel angiogram.
Okay.
Okay. Anju, I think.
Yeah, time is up.
So I'd like to thank Dr. Veena ma'am for that great insight into this topic, which was really a gray zone, and now it is full of colors. And yes, definitely we have understood so much. That's why we have so much of doubts and so much of participation too for this session. And really thank you for helping our PGs too. And I should thank Anju for bringing you in. We were really for it. There were a lot of hindrances, a lot of confusions, but we wanted you here and really it. Thank you, Anju, for that job too, and for moderating this session in a very beautiful way. I also thank the PGs for Dr. Mona and Dr. Jinju for their presentation and taking part in this so that even the other PGs can understand how they could face in the exam. And thank you all the senior teachers for participating in this and all my friends for this active participation and for the discussion too. Thank you all and good night.
Thank you.
Thank you. Thank you, ma'am, again.
Thank you so much, Dr. Veena. It was very good. Okay, everybody. Okay, Anju, thank you so much for arranging that. I guess it's time all of us said goodbye and good night. Anyway, it was our first scientific session for the year. And I'm very pleased the way it went. Thank you, Anju. Thank you, Bindu.
Thank you, Batsar.
Yeah, Batsar, thank you so much for participating.
Thank you, ma'am. Thank you. Thank you all. Thank you, Padmaja, ma'am.
Good night.
Good night.
Thank you, ma'am.
Bindu, all good things come to an end, right?
Participation also around 65%.
Okay, Bindu, time to end, I suppose.
Thank you.
Goodbye, everybody.
Goodbye.
Goodbye, ma'am. Thank you, ma'am.